So our last speaker for this morning's session is Dr. Jackie Kraft. She's one of our neurocritical care attendees. She'll be speaking to us about a year review in neurocritical care.
Thank you. Good morning. All right, so I have no disclosures. The objectives are to go over the MISTIE III trial and its implications in neurocritical care, as well as the extend and wake up trials and extended TPA administration times. So our first question, hemorrhagic stroke has a higher morbidity and mortality than ischemic stroke. What evidence-based practice are currently in place to decrease morbidity and mortality following hemorrhagic stroke? Your choices are A, blood pressure control, B, surgical evaluation, C, early hemostasis, or A and B, or A and C, or F, none of the above. You won't believe there's things to do. The answer is none of the above. All right. So we're going to talk about intracranial hemorrhage, and in that we're going to talk about the MISTIE III trial that came out actually just a few months ago. So there are over 5 million intracerebral hemorrhages every year worldwide. And the morbidity and mortality is astounding and much higher than that of ischemic strokes, which is why this matters. And unfortunately, there's no evidence-based treatment. So controlling blood pressure has been shown to not actually improve outcomes. Controlling bleeding doesn't improve outcomes. And all of our surgical trials thus far have not shown to improve benefit, to show benefit. So the MISTIE III trial, why was it done? So first there was the STITCH 1 and 2 trials, which the STITCH 1 and 2 trials were looking at craniotomy for surgical evacuation of hemorrhage. And basically both of those showed that early surgical evacuation does not decrease the rate of death or disability at 6 months. And so people said, okay, well, if we could, take away the bad effects of craniotomy, like manipulation of tissue, the need to give thrombin into the brain, electrocautery, by using a minimally invasive surgery, would that improve outcomes? And so that's how the MISTIE trial came to be. So in the MISTIE 1 trial, they evaluated the safety of this minimally invasive surgical technique with then infusing alteplase or TPA into the hemorrhage bed to decrease the hematoma burden. And so they showed that was safe, and so they did the MISTIE 2 trial to look for the best thrombolytic dose, and that also showed that there was a substantial treatment effect with a modified Rankin score of 0 to 3 at 1 year. So then we came to the MISTIE 3 trial, which just came out to show if this was generalizable to a greater population. So this was a phase 3 randomized controlled open label blinded endpoint trial. And what they were doing is doing image-guided catheter-based removal of the hemorrhage followed by infusion of TPA into the hemorrhage bed. All of these subjects were adults. It had to be due to a non-traumatic small vessel disease hemorrhage. So this does not include aneurysmal patients, AVM bleeds, no trauma, and no amyloid angiopathy. These are specifically patients that have been screened. They all had CTAs, sometimes MRI to prove if there was a concern for amyloid. These were all larger bleeds, so greater than 30 mLs. And then these patients had to have an injection stroke scale of greater than 6 and a GCS of less than 14. And they had to have good functional status prior to being enrolled. All right. So they were randomized with a computer database. There was a 72-hour window eligibility. So I think this is important because basically when patients came in, they had to have a stable CT scan for 6 hours. And if it wasn't stable for 6 hours, meaning the hematoma grew, every 6 hours after that, they could still be considered part of the study up to 72 hours. So even if it was right before 72 hours and that's when their stable scan was, they were still enrolled in the study. Okay. So how was this done? So the small borehole was drilled, then a rigid cannula was placed, and the blood was aspirated. Then they would place a soft catheter into what they believed the hematoma bed was, and they would get a CT afterwards to make sure that was in the right place. If it wasn't, they would replace the catheter again and again, all right? Once the CT scan was stable for 6 hours after the surgery, they would then infuse a 1 milligram and 1 ml of alteplase into the surgical bed, followed by 3 mLs of saline, and they would do that every 8 hours, up to 9 doses. And each time they would be clamping that catheter for about an hour, and then they would let it drain to gravity. So When do they stop dosing? So their primary endpoint goal was for the hematoma to be less than 15 mL. So if you reach that goal, they would stop infusing. If you reach 9 doses, or if there was clinically significant bleeding, meaning the patient had a change in their status. Then that was the MISTIE III group. That was the surgical procedure they got. And then there was the standard of care group, which basically got basic standard of care for an intracranial hemorrhage, which is blood pressure control, intracranial pressure management, and airway control, which is, since this was done in like 78 different hospitals around the world, either based on the AHA guidelines or the European Stroke Organization guidelines. And each group got the same amount of CT scans at the same intervals. So their primary outcome was a good functional outcome, which they define as a modified Rankin score of 0 to 3. So 0 is basically no deficits at all. 3 is a moderate disability, needing some help but being able to walk without assistance. And this was at 1 year because they showed in the MISTIE II trial that you couldn't stop the study at half of a year because patients just hadn't plateaued in their ability to improve, which we see in most neurologic patients. They need about a year to recover. And then their secondary outcomes were all-cause mortality, extended Glasgow outcome score, patient disposition, health-related quality of life, and then how much time were they in the ICU and in the hospital in general. So this is a big table with a lot of information you don't need to know. The big thing is just seeing that for the most part, the two groups were the same. The only two differences were the number of patients on anticoagulation. There were about 10% of the patients in the MISTIE group that were on anticoagulation versus 4 in the standard of care group. So that was a significant difference. And then the other thing is that in the MISTIE group, there were significantly less patients with lobar hemorrhages than in the standard of care group. And just in general, patients with lobar hemorrhages do much better than patients with deep hemorrhages, okay, or intraventricular hemorrhages. So, so the primary outcomes, let me see if this works. So what you're looking at here, is you're looking at the gray, blue, purple, and yellow, okay, in the top one, and that's their modified Rankin scores. And what you're seeing is that there's no statistical difference in their primary outcomes, okay, between the two groups. And then you look at the secondary, the one below is the secondary outcome score of the extended Glasgow outcome scale at 1 year. And again, you're not seeing any difference in the recovery, all right? It was 44% versus 42 if you want the numbers. So the other thing that they found is that is interesting and I think implicated in further trials is that in the MISTIE patients, only 58% reached that end goal of less than 15 mLs hematoma volume versus only 1% in the standard patients, which one would expect these are relatively large volume hemorrhages. If they're not removed, they're not going to get to that goal. But what they found is that this 58% who got to that goal, they actually had better functional outcomes. And so if you could actually get to that goal in the majority of your patients, would you have seen the outcome you were looking for? And what they found is that surgeons who did more of these procedures actually got to that goal faster. So the question is, if we train surgeons to do this more frequently, would you have a better outcome? And would this be a benefit? So, and then the other thing they found is just that ICP events were significantly higher in the standard of care group versus the MISTIE group, which makes sense because you're decreasing the amount of volume of blood within the head, so that makes sense. All right. Also was noted that all-cause mortality was significantly decreased in the MISTIE group. This was a secondary analysis, so they're saying this is more exploratory, but again, all-cause mortality was decreased in the treatment group. So the takeaways from the MISTIE trial, they can't recommend doing minimally invasive surgery with thrombolytics at this time. Though looking at kind of that group that got to less than 15 mLs, and with surgeons who are doing more and more of these procedures getting closer to that, you know, if further surgical training and better consistency among surgeons, would we get a better outcome? Also, would the location be different? You know, we had that significant difference in the patients who are in the standard of care group versus the treatment group having lobar versus deep hemorrhages. Would that have made a difference? And then the one big thing here is that we showed that the prognosis in these patients, when you looked at those outcomes, were actually better than we've ever thought hemorrhage outcomes could be. And we've been seeing that more in more recent trials, and that we used to say, well, these patients with these massive hemorrhages, they're not going to have good outcomes, so we should just talk to families about withdrawing care. But we've really improved neurocritical care and advanced, you know, surgical techniques, et cetera. And so not giving up on these patients, being as aggressive as we can. was one of the things, the writers took away from the study. There's also 3 ongoing trials with other minimally invasive techniques, so maybe next year we'll talk about one of those. So now we're going to talk about ischemic strokes. So currently, TPA guidelines recommend giving TPA up to 4.5 hours past last known normal due to concern for hemorrhagic transformation and completed strokes. What imaging modalities currently exist to better help determine core or completed stroke versus penumbra, brain at risk for stroke, in patients with prolonged last known normal or unknown last known normal? All right, so the answer is A and C. Okay. So currently, MRI brain and CT perfusion are what is recommended. So there are actually 2 studies in the last year that have come out looking at this. So the first is the Wake Up trial. And this specifically was looking at MRI changes. So patients who came in with prolonged last known normal or unknown last known normal were put into the MRI scanner hyperacutely, and what they were looking for was an MRI DWI change, but no parenchymal hyperintensity on the flare. And basically what this indicated to them was that the stroke had actually occurred in under 4.5 hours prior to this image being taken. But also indicated that there just wasn't a large core of stroke, all right? So they enrolled a little over 500 patients. Half of them received TPI and half of them received placebo when they found this on their MRI. Their primary endpoint was an MRS of 0 to 1 at 90 days. And basically what they found was that the patients who received TPA had significantly better outcomes. So favorable outcome in 53.3% of patients who got TPA versus 41.8%. Their median MRS in the TPA group was 1 versus 2, so needing help versus not needing help at all. And then there was not a clinically significant difference in hemorrhage, which is always an important thing we're looking at when we're giving someone TPA, so 2% versus 0.4%. The one thing that was different was the mortality. And looking at the study itself, one of the patients who died actually had a very, very large stroke, greater than a third territory, so shouldn't have been enrolled in the study to begin with. And another patient that died didn't have their blood pressure controlled, and so unfortunately had a very large symptomatic hemorrhage and died from that hemorrhage after TPA. But again, not a huge difference if you're taking away those 2 patients, but again, there was a significant difference per the study. So really, this was a really important study, and so we'll talk about the next trial, which was the Extend trial. So this actually hasn't even been published yet. This was just presented at the International Stroke Conference a few months ago, but has really important implications in stroke treatment. So that's what we're going to talk about. So this was called Extending the Time for Thrombolysis in Emergency Neurologic Deficits Trial, or Extend is the easier way to put it. And so what they were looking at was CT perfusion, and there was some MRI as well, but for the most majority, CT perfusion, because most patients in most centers can't get an MRI as quickly as you need to get in the Wake Up trial. So I think that CT perfusion is a much more widely available modality that more centers are going to have. So they were looking at the perfusion mismatch, which we'll go over, to evaluate for TPA administration up to 9 hours or with unknown last known normal. So this was unfortunately stopped early when the Wake Up trial results came out because it was recommended by kind of their governing board, and this was done in Australia, that it be stopped given the results of the Wake Up trial. So if you look at the left over here, maybe this is the right one? Yes, all right. Okay, so this is cerebral blood volume, cerebral blood flow, and mean transit time. And basically what you're looking for is when you have a stroke or a clot, you have decreased cerebral blood flow and increased mean transit time. And what you're looking for is to see, is the cerebral blood volume decreased or is it normal to increased, which would indicate that the area could be salvaged, okay? And the easier way to look at this is this new software, it's been around for a little bit, called Rapid Outputs, which is down here. So these are 2 different strokes, obviously, they're on different sides of the brain, but this is the best way to show it. What you're looking at here is in the pink or purple, if you can see that, that is completed core stroke. And if you can see on the bottom, the machine actually tells you this is 23 mLs. And then on the green is the area that's at risk. So you can see this is at risk for becoming a massive stroke, but it only has a small area of completed infarct, okay? So that's what we're looking at, is the area at risk versus the area that's been completed. So what they were looking at in the Extend trial is could we use this imaging to give TPA? So they enrolled 225 out of the planned 310, so the majority of their patients. 112 got placebo and 113 got TPA. To be enrolled, they had to have a hypoperfusion to core ratio of 1.2, a perfusion lesion core absolute difference of greater than 10 mLs, and an ischemic core lesions of at least 70 mLs. All right. So, when we look at this trial, the patients who received TPA overall were significantly older, 74 versus 70. Patients who received TPA were predominantly wake-up strokes, so 65%. 25% were at 6 to 9 hours, and 10% were at 4.5 to 6 hours. So in the patients who got TPA, the average time to TPA was 9.9 hours, and the control group was 8.9 hours. So both of those groups, that's twice our current guidelines when we give TPA. Their primary outcome was an MRS of 0 to 1 at 90 days. So they had two different analyses, the intention to treat analysis and the per protocol analysis. So the per protocol analysis, they just removed several patients who didn't fully meet all of their inclusion criteria, but they showed basically the same outcomes. They were both statistically significant in that the TPA patients did significantly better at 90 days than the placebo patient. And there was a 45% increase in the likelihood of a patient having a modified Rankin scale of 0 to 1 with thrombolytic treatment. It's a really significant difference. The secondary outcome was an MRS of 0 to 2, so 2, the patient may need more help in their daily care. But again, even in secondary outcomes, you saw a greater likelihood of neurologic improvement. You also saw an adjusted likelihood ratio of 90% reperfusion at 24 hours, which is really great. And then good functional outcome was 35% higher in the treatment group. So what were the bad outcomes? There were symptomatic intracranial hemorrhages in 1% of placebo patients and 6% of TPA patients. This may seem like a lot, but this is pretty standard for all TPA trials. About 6% of patients who have strokes will develop intracranial hemorrhage. There was, interestingly enough, no increase in mortality related to the increased hemorrhage rate. It's not significant. The mortality group was not, the mortality rate, was not statistically different, either. So the takeaways from this study, more patients will become candidates for treatment who previously showed up outside the window, which I think is really exciting in the stroke world. The one concern that's kind of been brought up again and again is the ability for these imaging modalities at smaller hospitals, because the benefit of this would be the patient can get their TPA before they get to our center, which decreases the core amount of stroke, and then they could be evaluated for thrombectomy at a larger center. And of note, no one in this study got thrombectomies, despite the fact that 70% of the treatment group and 74% of the standard of care group had large vessel occlusions that would have been amenable to thrombectomy. That's pretty significant. And so I think that seeing if we could get this imaging modality and get radiologists who are capable of reading these images in smaller centers, that's kind of the biggest limitation of this. But overall, with all the new things that are coming out, I think that stroke treatment is really exciting right now. So and that's the end, if anybody has questions. Yes, sir.
Has anyone ever done a study showing mismatch on such individual scans in patients with heart disease or this heart failure with pneumonia? In my experience, I've seen the concealed mismatch, and we got a case of a 37-year-old on the drugs, and we did a bedside evidence, we went to less than 35 to 20%, and we got a mismatch in the cycle of the case anyway, and had a great outcome. So we couldn't really know what CTQ was saying.
Right, and there's not a specific study that I can tell you, but I've seen that multiple times, and a lot of that just has to do with the bolus with people who have heart failure. A lot of times we're not getting a good CTA bolus, so seeing an occlusion is difficult, and also getting a good perfusion scan is difficult. So it's something that we always have to weigh the pros and the cons and know that that's a part of what we're seeing. That's a good question. Any other questions?
Other questions?
Thank you.